fact about vaccines, they prevent over 2.5 million deaths in a year worldwide, which is a significant number. Vaccines expose a person's immune system to a small amount of a virus or bacteria to confer immunity against it in case they're ever exposed. And this is especially significant for diseases which we don't have treatment available for, such as measles, or have very high morbidity and mortality rates, such as invasive pneumococcal disease. They're responsible for herd immunity, which is a form of indirect protection that occurs when a large percentage of the population has become immune to an infection, which then indirectly protects individuals who are not immune or are unable to get vaccinated themselves. And I cannot stress enough that there is no evidence within any literature that links autism to vaccines. Okay, so in 1796, Dr. Jenner discovered that if he infected people with the related but relatively benign cowpox virus, he could actually inoculate these patients with a much lower mortality rate. So that was the beginning of the concept of vaccines. And then vaccine development finally made another major step about 85 years later, when Dr. Pasteur identified bacteria as a major culprit behind several diseases, and then used this knowledge to produce the first lab-made vaccination. Knowledge of the procedure then spread rapidly and became common throughout the world. And 11 years later, vaccines for cholera and typhoid were developed, which both had very high rates of mortality. Eventually, these methods for growing viruses in the lab led to discoveries and innovations, and then led to vaccines actually being recognized and licensed as medicines in 1914 for the first combination vaccine, which contains diphtheria and tetanus, to be licensed in the US. Okay, and there have been significant reductions in the rates of infectious diseases in the US throughout the 20th century, as you can see here. In the early to mid 1900s, people lived in fear of being stricken with diseases such as polio, diphtheria, smallpox, tetanus, and beginning with the licensure and combined diphtheria and tetanus toxoid and pertussis vaccines in 1947, so around here, the state and the local health departments then started to institute vaccination programs that helped increase the distribution and availability of the vaccines. And in 1955, the introduction of the polio vaccine, right here, led to federal funding of state and local childhood vaccination programs. Then a little bit later, in 1962, this prompted coordination of a vaccination program that was established through the passage of the Vaccination Assistance Act, which supports the purchase and administration for a full range of childhood vaccines. So that really helped the deaths in the 19th century really come down here, in the 20th century, sorry. Okay. All right, so now that we covered some background about vaccines, in this section, we're going to review the fundamental concepts of immunology and describe how vaccines elicit an immune response. It's going to be a simple abbreviated version because the immune system is a very intricate and complex system. So we're going to try and just cover what we can for our purposes. Okay, so the immune system's primary function is to identify foreign substances in the body, whether it be bacteria, virus, fungi, transplanted organs, etc., and develop a defense against them. This defense is known as the immune response. So there are two components of the immune system. The first component is our innate immune system, and that is the body's first line of defense. So these are defenses that a person is born with, and there is a pattern of recognition that elicits a response for all antigens in the same manner, even with re-exposure. So if a pathogen gets past this first line of defense, then the immune system is capable of generating a more specific immune response to eliminate it, which is our adaptive immunity. So our adaptive immunity is different in that it's more specific towards an antigen. It's formed by past experiences with either a pathogen or a vaccine. It includes two cell lines that are responsible for producing a more robust immune response through memory, and those are our B cells and our T cells. So antigens, which in this case are pathogenic organisms such as viruses or bacteria, trigger the immune responses through certain molecules on their surface. The immune system is always surveilling for foreign organisms that are a potential threat, and the way it can differentiate between which cells are healthy and which cells are dangerous or a threat is through the major histocompatibility complex, or the MHC. So the MHC are proteins that are recognized as antigens on the surface of cells, and they're the most polymorphic genes that are known to humans. The humoral immune response is mediated by the B cells. Humoral actually means antibody, and each B cell has a unique antibody in its surface that will bind to only one specific antigen. In the primary encounter with this antigen, the B cell will bind to it, engulf it, and then digest it. So once it's digested, the antigen is broken down into pieces that bind to the MHC and form a complex. So the MHC antibody complex is then presented on the surface of the B cell, as we see right here, and then attaches to a matching T cell. Okay. So once the B cell, the MHC antibody complex binds to a T cell, then the T cell releases interleukins, which is a cytokine and then can act as an intracellular messenger. So the interleukins then cause the B cells to multiply and mature into either plasma cells, and they release millions of copies of the antigen-specific antibody to eliminate the antigen, and then others actually mature into memory B cells, and these are capable of storing the memory of the specific antibody to the antigen and aren't filtered out or eliminated. So once an antibody binds to the antigen, the complex is then marked for destruction, and the immune system eliminates the antigen-antibody complexes using specific immune cells. So the macrophages, or immune processes like the complement system, which has several functions, including marking cells for phagocytosis and lysis of the target cells. Okay, and then some diseases such as varicella or herpes zoster are more susceptible to cell-mediated immunity. So cell-mediated immunity relies primarily on our T cells, which include both our helper and our cytotoxic T cells. The helper T cells don't bind directly to antigens found in the bloodstream like the B cells. Instead, as noted in the discussion of humoral immunity, these helper T cells recognize and bind to MHC antibody complexes that are presented on the surface of the other cells. So our antigen-presenting cells like our macrophages, our B cells, and our dendritic cells. So like B cells, macrophages engulf and destroy these pathogens, digest them, and then present the MHC antibody on their surface. And when the helper T cells are activated, they secrete cytokines, such as the interleukins we spoke about earlier, that trigger several actions. So in addition to stimulating the production of additional B cells, these cytokines recruit additional immune cells to the site of the infection. The helper T cells also activate cytotoxic T cells, which are able to independently identify and kill infected T cells, as we see here. All right, and while antibodies that are produced during the humoral immune response can wane over time, protection can still actually remain. So in addition to triggering proliferation of these clone cells and the resulting antibodies, the humoral immune response produces memory B cells that contribute to that continue to circulate after the infection is cleared. So when this immunity is done, subsequent to receiving a vaccination, this process is actually referred to as priming. This is considered sort of an artificial induction of immunity, and in order to protect against infectious diseases, the priming involves sensitizing or stimulating an immune response with an antigen. So if a person is exposed again, the secondary response to the antigen will be much more robust, as we see here. All right, and immunity can be acquired through either active or passive means. So active immunity is acquired through actual exposure of a natural live pathogen, either following an infection or through vaccination, and results in the immune system responding and developing antibodies towards that pathogen, and that confers long-term protection and immunological memory. And the examples I mentioned here are exposure to the pathogen or vaccines. And then passive immunity, on the other hand, is actually acquired through transfer of antibodies and confers short-term protection because it isn't able to elicit a cellular response. Examples of this are passing on immunoglobulins from the mother to a fetus, or an infusion of immunoglobulin. All right, so we have a learning question. If you could respond in the chat, what type of immunity is responsible for eliciting a response once re-exposed to a specific antigen? Is it passive immunity, adaptive immunity, innate immunity, or all of the above? Oh, thank you, Melinda. Yep, it's B. Thank you, Maura. Yep, that's correct. The answer is B. It is adaptive immunity. Okay. All right. In this next section, we're going to be speaking about the different types of vaccines we have available and the differences in the immune response between them. Okay. So, I don't know why that's there. So, the two major types of vaccines are our live attenuated or weakened vaccines and inactivated vaccines. So, the response to live vaccines is the most similar to that following an infection. So they're able to produce a more persistent immunity as compared to the inactivated vaccines, since they contain a weakened but still live version of a bacteria or a virus that's enough to replicate and elicit an immune response, but not enough to cause disease. So inactivated vaccines, on the other hand, contain portions of the virus or bacteria that are enough to induce antibody production, but without cellular recruitment. So in other words, they don't actually involve too much of our T cells. So because they produce very little to no cellular immunity, the booster doses are often needed to sustain these protective levels of antibodies, since they can diminish over time. All right. Okay. All right. So the list here of our live attenuated vaccines, we have the cholera vaccine, Vaxchora, our oral typhoid vaccine, Vivotif, the Zostavax, which is the live zoster vaccine, yellow fever vaccine, the Flumist, which is our live influenza vaccine, varicella, rotavirus, and the measles, mumps, and rubella. And then we also have the MMRV, which is the Proquad, and that is the MMR plus the varicella antigen. And so just a nice way to help you remember this is Cozy IV Room. A nice little mnemonic to remember which ones are live. Okay. All right, so the inactivated vaccines have several types and have varying degrees of immune responses depending on the type. So they contain either parts of the virus or bacteria that are considered immunogenic, which means they're able to still produce a reaction. The first type of inactivated vaccines is our polysaccharide vaccine. And this contains the external capsule of the bacteria so that immune response can recognize it as an antigen and elicit a response. However, they do not include or involve cellular immunity. So the B cells aren't able to mature into plasma cells or memory cells. And consequent to that, the antibody response weans over time. The only available licensed polysaccharide vaccine in the US right now is the Pneumovax 23, which is indicated for the prevention of invasive pneumococcal disease. right, the next type of inactive vaccine are the conjugate vaccines. So they're actually also polysaccharide vaccines, only they're also conjugated to a protein carrier. Proteins are immunogenic, and they actually require for the T cells to process them and then present them to the B cells, which subsequently leads to development of memory B cells. And so we have a much more robust response than the polysaccharide vaccines. Examples of this are the Prevnar 13, which is also indicated for invasive pneumococcal disease, and the Menactra, indicated for invasive meningococcal disease. All right, so the next type of inactive vaccine is a recombinant vaccine. So the recombinant vaccines take a small piece of DNA from the virus or the bacterium against which we want to protect. This is then inserted into other cells to make them produce large quantities of active ingredients for the vaccine. They're also able to stimulate both B and T cell responses, and examples of this are Gardasil, which is for against human papillovirus or HPV, or Flublok, which is indicated for prevention of the flu. The last type of vaccine we have here are the toxoid and acellular vaccines. So they're also protein-based vaccines, so they're able to recruit both our B cells and our T cells. They contain either a toxin produced by certain bacteria, so they're able to evoke a protective antibody response after the injection, because it's the toxin that's actually the immunogenic component of the bacteria or the virus. But it's actually an inactivated toxin, so it's unable to actually produce any sort of harm. And then the acellular vaccines contain components of a cell, but not the whole one, so they're also unable to cause any sort of disease. And they're able to evoke a protective antibody response, but we have to make sure we obtain boosters every couple of years because they do wane over time. Okay, another learning question. So Pneumovax 23 is classified as what type of inactive vaccine? If you could just put the answer in the chat. Yep, okay, Maura, you're right. It is C. Yes, thank you, Tyler, it's C. All right, so we're gonna discuss right now the different indications for vaccines and define what is an immunocompromised person and what renders them immunocompromised. Okay. So we have national evidence-based vaccine recommendations written by the CDC Advisory Committee on Immunization Practices, so the ACIP, and then they incorporate them into a schedule, as you see here, that's actually updated annually. And this vaccine schedule is not a one-size-fits-all. So some groups have a higher likelihood for contracting certain diseases than others, so they're indicated to receive more vaccines than the normal populations. And here we have examples such as women who are pregnant, immunocompromised patients, we have patients with diabetes, pediatrics, end-stage renal disease, or heart and lung disease. So the focus of our talk will actually be immunocompromised patients, and they can be addressed as immunocompromised, immunosuppressed, or immunodeficient, and they can actually be classified either further into either primary or secondary immunodeficiency. So primary immunodeficiencies are inherited, and inherited, the term primary immunodeficiency refers to a group of over 130 disorders that result from defects in the immune system, development or function. So here we have DeGeorge syndrome, which is a type of T-cell deficiency. We have chronic granulomatous disease, which affects phagocytic function, and we have IgA deficiency, which is an antibody that's released in mucosal secretions, and these all lead to a type of primary immunodeficiency. And then we have a secondary immunodeficiency, and this is acquired through many different ways. And it's important to note that immunodeficiency is a spectrum, but ultimately it leaves a person more susceptible to having severe infections. So here we're going to talk about the more severe types of secondary immunodeficiencies. So the examples here as what qualifies a person as severely immunodeficient, we have patients who have HIV with a CD4 count of less than 200, so they have AIDS. We have a person who's received a solid organ transplant and then on immunosuppressive medications. We have patients with hematological malignancies, patients who've gotten hematopoietic stem cell transplant, on radiation or chemotherapy and immunosuppressing medications, which is defined as greater than 20 milligrams of oral prednisone or any sort of steroid equivalent for greater than 2 weeks. Patients who are taking monoclonal antibodies, TNF, or interleukin inhibitors. And what is unique about these populations is that for some of them, we actually have specific guidelines or studies that outline vaccines that are indicated that we primarily follow and then supplement with the CDC ACIP schedule. So for most of these other populations that we saw here, we actually just follow the CDC schedule, but we usually have other guidelines and studies that we follow for this population. Generally, live vaccines are contraindicated, but inactivated vaccines should be administered. And household contacts of immunocompromised people should actually receive vaccines as per the standard vaccine schedule because it will not cause any harm to their family or whoever they are living with. All right, so since this population is so vulnerable, we have to try and balance safety and efficacy of the vaccines we're administering. So in general, all inactivated vaccines can be administered safely to the immunocompromised patients. And the risks don't outweigh the benefits of vaccination. But on the other hand, the response of these inactivated vaccines might be suboptimal and may require additional booster vaccinations to maintain an adequate amount of antibodies to confer protection for the specific population. The patients with secondary immunodeficiencies don't have adequate cellular defenses as immunocompetent individuals, so they're unable to halt replication of the disease. So remember how we were talking about before for the live vaccines, and we said it contains a weakened version of the virus, but it's able to multiply enough for the competent immunocompetent person to be able to halt the replication but still cause like an antibody and cellular response. But this specific population is not able to do that. So they're unable to halt replication of the disease within the live vaccine to achieve immunity. So administration can actually lead to disease manifestation. So in this case, the risks outweigh the benefits. And so if a patient is indicated for a live vaccine, it's recommended that it's either administered before or after periods of a planned immunosuppression if possible. And so here's our slide again of the live vaccines that are contraindicated in this population due to either limited or no data regarding safety and immunogenicity. And the data available really renders them unsafe, and that is why they are contraindicated. So we just have another checkpoint learning question. Which of these vaccines can lead to uncontrollable replication and disease in a patient who is on prednisone 50 milligrams once daily for 3 months? Yep. That is correct. The answer is C. Thank you. All right. Moving along. All right. So now we're going to get into our CE and talk about which vaccines are indicated for this specific population. So first off, I want to talk about the influenza virus. Yes, it is indicated for everybody, but more so for this population. So the influenza virus is a highly infectious respiratory illness that's caused by an RNA virus of the orthomyxovirus family. It has three major subtypes, A, B, and C, and it changes seasonally because of its surface proteins. The hematoglutinin and the neuraminidase are able to mutate, and we're able to get an antigenic drift every season. So we have to make sure we revaccinate every season. So it's spread by respiratory droplets or direct contact. And really the most effective strategy to prevent it is vaccination. And once a person does contract it, most of the treatment we have is supportive care, and most patients will be able to get by with supportive care. But for our immunocompromised populations, there are much higher rates of complications. So 70% of our solid organ transplants patients who contract the flu actually require hospitalization, which then often leads to a superimposed bacterial pneumonia, or for our cancer patients, delays in chemotherapy treatment. So these patients are also much sicker for longer, with an increase in viral shedding time of 20 days versus 1 week in patients who are immunocompetent. And then you have much more admissions to the ICU, and which requires invasive ventilation. All right. There are many different types of formulations influenza vaccines available. The key differences between them really include the number of strains. So 3 is trivalent. It has 2 A strains and 1 B strain. And then we also have the quadrivalent, which has 2 A strains and 2 B strains. Another difference is whether the virus is inactivated or live, which we discussed before. So we have 2 inactivated, and then we have 1 live type of vaccine, which is the Flumist. The route is also different. So most of them are given IM, but some, such as the Fluzone over here, is actually Fluzone intradermal, is given intradermally or intranasally, such as the Flumist quadrivalent. And then the antigen dose or the presence of an adjuvant can also differ. So inactivated influenza vaccines are actually produced using eggs unless otherwise noted, which can be problematic for patients who have an egg allergy. Okay, so in terms of which patients get what vaccine, so the flu block, in our patients who have an egg allergy, the flu block does not contain egg protein. So they are indicated, if they're 18 and above, to receive the flu block vaccine. And in patients who are over 65 and require high doses, they often require high doses because these vaccines actually contain about 4 times the dose of the antigen, and the studies found that it was more effective than the standard dose trivalent vaccines at increasing antibody production. The Fluad contains a water and oil emulsion to increase antibody production. With these specific ones that contain a higher antigen dose, they have been studied in our immunocompromised patients, specifically in HIV patients, but the data really is scarce, and it doesn't go in a way where we can either recommend it or just, it's very indifferent, so we just recommend it based on their age and their allergies. But the most important thing to note here is the Flumist is contraindicated because the risks are unknown of the complications in most populations. Okay, the next type of disease we want to vaccinate the whole population for is pneumococcal disease. So this is caused by Streptococcus pneumoniae, which is a gram-positive diplococci bacteria. It's also spread by respiratory droplets or direct contact with the infected droplets. Manifestations that we usually see are, pneumonia, bacteremia, meningitis, sinusitis, or otitis media. But in terms of invasive pneumococcal disease, we're going to see bacteremias and meningitis. Okay. All right. So like we saw with influenza, these patients are much more likely to have complications from these diseases. So it's 25 to 30 times more common in our transplant recipients than our regular population. It has the ability to manifest as a disease more severe than a pneumonia, such as a bacteremia or meningitis, and can cause significant amounts of morbidity and mortality. And the patients at the highest risk of these complications are the focus population of our talk today. The high rate of incidence and complications really stress the need to administer vaccines to actually prevent it. All right, the two pneumococcal vaccines available on the market are the polysaccharide Pneumovax vaccine and the conjugate Prevnar 13 vaccine, which we spoke about a little bit earlier. So the Pneumovax has actually been around since 1983, and it has no clinical trials to prove its efficacy. And as we discussed before, it doesn't confer any T-cell mediated immunity. So we don't get any lasting response, and we often actually have to revaccinate our patients. Prevnar, on the other hand, has been available since 2010, and although it only contains 13 serotypes of the disease, it induces T-cell involvement, and it's able to produce a more long-lasting response as proved by the Capita trial. In 2010, it was a double-blinded, randomized, parallel group, placebo-controlled vaccine efficacy trial. It compared Prevnar 13 patients to a placebo, and it was done in 84,496 immunocompetent adults over 65, and it showed that 46% of the patients actually had a significant, in the control group, in the Prevnar group, had a significant risk reduction of the first episode of a pneumococcal, bacterial, non-bacteremic community-acquired pneumonia, as well as vaccine-type invasive pneumococcal disease that were covered by these serotypes. All right, the usual interval between these vaccines is 1 year, but we actually recommend an 8-week minimum if no prior pneumococcal vaccines. So the usual interval is 1 year, but a shorter interval of 8 weeks is used in immunocompromised patients to provide protection more quickly. And then multiple doses of Pneumovax are separated by at least 5 years. So if you've received a prior vaccine before, which is most likely going to be Pneumovax, then you're going to wait 1 year minimum, just for the purposes of lining it up with doctor's appointments. And then you're going to get 8 weeks later another dose of Pneumovax. But as always, we're going to separate both doses of Pneumovax by at least 5 years. All right, as a summary, these are the vaccines indicated for the patients with our secondary immunodeficiencies. So influenza, either trivalent, our inactivated trivalent vaccines or inactivated quadrivalent vaccines. And against Streptococcus pneumoniae, we can administer Prevnar or Pneumovax 23 based on the schedule that we just covered. All right, so learning question. Mrs. PV is a 65-year-old woman who is taking prednisone 50 milligrams once daily for 3 months for her rheumatoid arthritis. She would like to receive her flu shot. As you are checking the prescription, you notice that it is the live Flumist quadrivalent. What is your next course of action? Are you A, going to fire the technician who selected the vaccine? B, okay, yep, Tina's right. It is C, administer the inactivated Fluarix quadrivalent vaccine. As long as it is an inactivated vaccine, she can receive it. So it could be trivalent or quadrivalent. All right, another question. So Miss Amal is a 35-year-old woman who has recently had a kidney transplant. She reports receiving Pneumovax 23 while she was on dialysis a year prior, and now she's here at your clinic. What vaccination is she due for? Yep, The answer is B. That is correct. All right. So we're going to review specific bacteria and viruses and why they're indicated for certain populations within our special population. All right, so hematopoietic stem cell transplant patients. So patients who've received a stem cell transplant, regardless if it was autologous, so their own stem cells, or allogenic from a donor, are at a much higher risk, according to the literature, of developing invasive infections due to Haemophilus influenza type B between 3 to 12 months after their transplant. So for this reason, these patients are indicated to receive 3 doses of the Hib vaccine, 4 weeks apart, about 6 to 12 months after their transplant, regardless of vaccine history. And what's really interesting about this bug is, yeah, it's a gram-negative coccobacilli and it's spread through respiratory transmission, but it's actually rarely seen in patients who are older than 5 years of age. So this vaccine isn't actually indicated for people who are over 5 years old, but according to the literature, since it has a much higher risk in this specific population, it's actually indicated for patients who've received a hematopoietic stem cell transplant. It's capable of causing invasive diseases that have significant sequelae, such as deafness and neurological complications, such as seizures, in like 30% of the survivors. All right. So here are the 3 vaccines on the market that are all conjugate vaccines and can be given as a 3-dose series to any of our patients 6 to 12 months post their transplant. Otherwise, patients who are less than 5 are indicated to receive one of these vaccines. So they can receive either these vaccines. They're indicated to receive 3 of them, 4 weeks apart, 6 to 12 months post their transplant. All right. Okay, next disease we're going to be talking about is meningococcal disease. It's caused by Neisseria meningitidis, which is a gram-negative aerobic bacterium. It has a polysaccharide capsule that actually surrounds the outer membrane and helps it evade phagocytic cells. It's classified into serogroups based on the structure of that capsule, and we have 5 here in the US that are the most common causes of invasive disease. So we have A, B, C, Y, and W. And manifestations include meningitis, bacteremia, or bacteremic pneumonia, but the most common form of invasive disease is meningitis. So this is specifically important to note about our HIV patients. So patients with HIV are one of the groups that have been shown to have about a 5 to 13 times higher risk for meningococcal disease than the regular population. So for this reason, this population is indicated to receive 2 doses of 8 weeks apart of the quadrivalent vaccines, Menactra and Menveo. So these vaccines contain serotypes A, C, W, and Y. HIV-infected persons haven't been demonstrated to be at an increased risk of the serogroup B disease, and therefore the use of the serogroup B vaccines, so the MenB vaccines, hasn't been studied in this group. And for this reason, it's not recommended for HIV-infected persons unless they have another indication for the vaccine. But typically, we only recommend the quadrivalent meningococcal vaccine. Another group that's at a higher risk of contracting meningococcal disease is our patients who are on eculizumab. So eculizumab is a monoclonal antibody that inhibits formation of the terminal complement complex, and it's indicated for atypical hemolytic uremic syndrome, which is a genetic disease that causes blood clots affecting your vital organs. So because this drug binds to C5 and inhibits the terminal complement pathway from forming and causing lysis of the pathogen, what we've seen in the studies, the package insert studies for eculizumab, is that the risk is 1,000 to 2,000-fold times greater among the patients on this medication, and that's why it's actually got a boxed warning regarding the development of meningococcal infections. So the recommendation for this is to immunize the patients with the meningococcal vaccine at least 2 weeks prior to administering the first dose of eculizumab. So they should receive actually both serotypes all all 5 serotypes. So they should receive both types of vaccines, the quadrivalent ACWY and the serogroup B vaccines. So the quadrivalent vaccine, they are indicated to receive 2 doses 8 weeks apart, followed by revaccination every 5 years. So the first dose will be 2 weeks prior, and then we can repeat it after. And then for the Men B, the schedule is according to the specific vaccine, which we will actually just go over right now. So the 2 types of vaccines, we have the quadrivalent, like we spoke about before, and the serogroup B. So they are both conjugate vaccines. In terms of the quadrivalent, we have Menactra and we have Menveo. And the special populations who are at high risk, who are able to receive this vaccine over 55 years old, we have patients with an HIV infection, which we touched upon, and patients who are using eculizumab. And for the serogroup B, the vaccines are Bexsero or the Tremenda vaccine. And really this is just these are the patients who are at high risk, and notice how eculizumab is also included in this list. Okay, so another group that I just wanted to touch upon is our patients on rituximab. So Rituxan or rituximab, it's a monoclonal antibody that is active against CD20 antigen on the surface of B cells. It's indicated for the treatment of non-Hodgkin's lymphoma or rheumatoid arthritis, but it also has a lot of off-label uses, as we've seen. Based on the studies, the B cell recovery is delayed for about 6 months after the last dose. So inactivated vaccinations aren't recommended within 6 months of the last dose of rituximab. And this is based on one study that evaluated the titers against the inactivated flu vaccine in patients who were taking it for the indication of rheumatoid arthritis. So this study, it was published in 2010. It was a prospective longitudinal cohort study, and what it did was it evaluated 72 patients for the levels of antibodies against the influenza vaccine. So all patients received the trivalent influenza vaccine, and they looked at the levels of the antibodies 28 days after vaccination. So 23 of those patients received rituximab, 20 of the patients received methotrexate, and 29 were actually healthy controls. So they measured the geometric mean titers of the antibodies, and what they found was that they were increased in both the control group and the methotrexate group. So this was not necessarily a finding in all patients with rheumatoid arthritis. This was just very specific to rituximab, where they did not see an increase in the geometric mean titers of antibodies against influenza. So based on this study, rituximab, they concluded that rituximab reduces humoral responses following influenza vaccination in these patients with modestly restored response 6 to 8 months after vaccination, because they've noticed that in the patients who had received rituximab about 6 months earlier and had actually discontinued the therapy, yes, they had a lag in the antibody titers, but they still had more than the patients who were actively receiving rituximab. And I wanted to put the study here just to show that this is pretty much telling of all of the data that we have on vaccines, where we find a correlation and then we extrapolate it or apply it to a lot of our other populations, but because our data is not very strong, but we still apply it to our patients. So we have to look at each specific indication and see what data does, if we're looking at a certain vaccine, and see what data does exist for that specific vaccine in the specific population, because most of the guidelines that we have are very generalized. Okay, and in terms of pediatrics, it's very indication and immunosuppression specific, and it could honestly be its own CE. You can safely, as with the rest of the population, receive inactivated vaccines based on the recommendations, but you have to weigh the risks and the benefits for live vaccines. So generally, we aim to vaccinate at the lowest point of immunosuppression in these pediatric patients. So for example, if they are on maintenance immunotherapy after they go into remission, or if maybe their CD4 counts are greater than 200 cells, then that is the time you want to aim to vaccinate with these, with the live vaccines or the inactivated vaccines. Okay. All right, and in terms of our special population summary, so just to go over this special population, for patients who have a stem cell transplant, they are indicated for the flu as well as the pneumococcal, but also because they are at an increased risk of the Hib, they are also indicated for Hib vaccines. In terms of our HIV patients, since we saw a higher chance of the meningococcal meningitis, we recommend that they receive meningococcal quadrivalent vaccine. For our patients who are taking eculizumab, we recommend that they receive the meningococcal quadrivalent and serotype B conjugate vaccines. And for pediatrics, it's indication and immunosuppression specific. And for our patients taking rituximab, the inactivated vaccine is advised for 6 months after the last dose because of the lack of efficacy. All right, so we have one more question here. Just to go over what our last section, Mr. JP is 65 years old and he has recently had 6 months prior an autologous stem cell transplant. Which one of these vaccinations is he indicated for? Yep, that is correct. He is indicated for both Hibirex, which is against the Hib, and Fluzone, which is against, the flu vaccine. All right, other considerations. So timing in this scenario is key. So there are certain windows of opportunity before initiation of the planned immunosuppression. So if it's feasible to administer it before, then that is what we would like to do for a live vaccine. So live vaccines should be administered about 4 weeks prior to immunosuppression, and inactivated vaccines should be administered at least 2 weeks prior to immunosuppression, but that should not delay the indicated treatment so you can complete the vaccines. All right, let's see. All right. And so you can get an inactivated vaccine at any point within the immunosuppressive state, but some exceptions actually do include within 3 months of a stem cell transplant and chemotherapy treatment, because we want to allow enough time for the humoral and cellular immunity to be partially reconstituted after the transplant and the chemotherapy treatment. During the time of induction and consolidation chemotherapies for hematological malignancies, hematological malignancies often go in intensification of therapies. So the more intense therapies are induction and consolidation. And then during maintenance chemotherapy, they are less immunosuppressed than those very intense chemotherapy cycles. So we would like to administer vaccines in this point in time if possible. And then treatment with rituximab, as we mentioned before, B-cell recovery is delayed for 6 months after the last dose. So we recommend that we vaccinate about 6 months after discontinuing. All right, in terms of household immunizations, so immunocompetent persons, as we touched upon before, who live in a household with immunocompromised patients can actually receive inactivated vaccines as per the CDC updated vaccine schedule, and they can actually also receive live vaccines except the live flu vaccine within 2 months of a hematopoietic stem cell transplant, because these patients still have a very weak immune system that is building itself. So they're severely immunocompromised and require 2 months before they engraft or develop a mature immune system. And even a small amount of shedding will be enough to cause disease. And persons who develop skin lesions after an MMR or a varicella vaccine, because those skin lesions can actually shed the disease as well. And infants who have been vaccinated with the rotavirus vaccine for 4 weeks after vaccination, because the virus can also shed in their stool. Okay, and in terms of resources, no one expects everyone to remember the details of the immunization recommendations. So we have our CDC guidelines that we spoke about before. We have the IDSA guidelines for vaccination of the immunocompromised host. We have the CDC ACIP schedule. And the specific resources that I had mentioned prior, we have the American Society of Transplantation Infectious Disease Community Practice. So this is specific for solid organ transplant patients. And we have vaccinations of hematopoietic stem cell transplant recipients. So this is specific for our stem cell patients. All right, and I thank you guys for attending this talk. You can feel free to ask me any questions if you'd like. I'll unmute you 1 second.
I don't know, he said he's gonna finish up tomorrow, whatever that means.
Okay, you guys, if anybody has any questions, you can type them in the chat or you can unmute yourself and ask. Okay, all right.
Hey, it's Amanda.
Hey, Amanda.
Just wanted to let everyone know, if you're listening in, if you have a question, if you go to participants at the bottom bar, and that's where the button is to unmute yourself. But thanks for the presentation.
Thanks, Amanda. Okay, all right. Let's see. So we can just go over the questions now. Oh, okay. You have a question? Oh, thank you, John. Thanks, John. Okay, just one more time. The person who is calling in from their phone, the phone number ends with 734. If you could just type in your name so we can take attendance. If you can unmute yourself.
Oh, I fell asleep. No, I'm only kidding. Can you hear me?
Hi, Melinda.
Hi. Yeah, it's 3734. That's me.
Oh, hey. Okay. Oh,
Okay,
that's
all
weird
right.
because you're also signed in as M Monteforti.
Yeah, you told me to sign in, so I did.
Oh, the best.
Yeah, that's me. That's me. Okay.
I was confused. Okay, cool. Thanks.
Okay. All right. Okay.
All right. Thank you, guys. I'll email everybody the questions, and you can just email me back the post assessment, and I will give you the CE code. Okay. All right. Tyler just emailed everybody the SurveyMonkey link. He just posted it in the chat, so if you can just click on it, or I can also email it. And once you take it, just let me know, and I'll send you the CE code. That's okay. All right, if anybody has any questions or is confused as to how this process will go, just reach out to me. I'll be more than happy to help. Okay, all right. Thank you so much, everyone, for attending, and I hope you have a great night. Take care.
Thank you.
Thank you.